Good afternoon, everyone. Today I'll be discussing one important topic. I think we should have started it with that, but we have discussed almost most of the topics in clinical cardiology, and one of the most important and the basic topic left is cardiac impulse. So cardiac impulse includes the inspection part, the palpation, and the percussion of the major cardiac areas, and to how to reach a diagnosis and how to interpret the cardiac impulse based on this. So before going to the cardiac impulse, there may be, yeah. So this is we know the anatomy of the heart. We have the four important areas known as the right and left second intercostal space, which has the aortic area, pulmonary area. We have the left third and fourth intercostal space where we have the herbs area. Then we have the left lower sternal border. We have the tricuspid area, and then we have the mitral area. So we know the right heart border is formed by the SVC, right atria, and the IVC, whereas the left heart border is formed by the aortic knob, the main pulmonary artery, and then the left heart border by the LV. And in between, we have the left atrial appendage, which is enlarged in cases of rheumatic mitral stenosis. So initially, the Egyptian physicians and priests employed the technique of palpation, and it was one of the techniques of examination in the ancient Greece. Then the John Nicolas Corvisart, he was a French physician, pioneered the art of bedside inspection and palpation of the precordium. In the current generation, we know we emphasize very not too much on the cardiac inspection and palpation, and our major diagnosis is made only at the end of auscultation. However, it is a good practice if after a good general examination and after the inspection and palpation, we can arrive at a differential diagnosis and can conclude what all inference we can take from the inspectory and palpatory findings. So the cardiac examination includes a general examination related to the heart and the regional examination. I have already discussed in my previous classes the important general examination, including the JVP and the other head-to-toe findings. So in this class, we will try to focus more on the regional examination of the precordium. So the precordium, as we all know, consists of inspection, palpation, percussion, and auscultation. Most of the auscultation we have already discussed, including the heart sounds, murmurs, and all others. Other important thing includes the inspection, palpation, and percussion, which at current era we do not lay much emphasis on. So the inspection involves the inspection for the chest wall abnormalities, the position of the trachea, the apex beat, other pulsations, dilated and engorged veins, and the surgical or any scars. Among this, the apex beat is something which we will discuss along with the palpation, as most of the time the apex beat is very difficult to make out by inspection, and only at the end of palpation we can derive at a conclusion on a apex beat. The position of trachea is more important related to respiratory system as compared to the cardiovascular system. So the other findings on the chest includes the chest wall abnormalities. When you see a patient with cardiovascular system, you may see something known as something like a pectus excavatum or a carinatum. We know the excavatum, though the name suggests it's excavate, it is actually an inward movement of the lower rib cage, whereas a carinatum is an outward bulging of the lower part of the rib cage. So we can find it in many cardiac conditions, including the abnormalities like the Marfan syndrome, which can have mostly the pectus excavatum, but it can also have carinatum. In patients with straight back syndrome or thin chest wall, we have something known as the pectus carinatum. Apart from this, some other syndromic conditions may cause the pectus excavatum and carinatum. Next, we can have the kyphosis and scoliosis. And now, why is kyphosis and scoliosis important in cardiovascular condition? Is it can alter many of your findings. So, apex, which you can expect on a fifth intercostal space, you may be able to, you may find it in the sixth intercostal space or diffuse or projected laterally and downward. So, kyphosis and scoliosis is something which can alter many of your cardiovascular findings. Even, yeah. And then we have the precordial bulge. So at the if you find a precordial bulge, we know a precordial bulge suggests a chamber enlargement before the fusion of the costochondral joint or the junction. So precordial bulge is an important finding which is seen in many of the congenital conditions because the chamber has enlarged before the fusion of the this costochondral junctions. Then we can find the distended veins over the chest. We know in patients with SVC obstruction, we can find a caudal, the veins may be running caudally, and in cases of IVC obstruction, you may find a distended veins which are running cranially. So distended veins over the chest wall is important, and also in cases of Budd-Chiari syndrome, which though is a condition more discussed in the abdominal examination, distended veins may tell you many of the findings. Then we can have something known as the collateral arteries, which we see in mostly in cases of coarctation of aorta, which because of the coarctation, many collaterals are formed. And these collaterals are usually seen in the interscapular area and the infrascapular area. And these are usually known as the Sussman sign. Sometimes we may even be able to palpate these collateral arteries. So these collateral arteries are found usually in the posterior part of the chest and in the inter and infrascapular area, and this is known as the Sussman sign. Apart from this, you should always look at various pulsations. Here I have written down various pulsations which you have to see in all the cases of cardiovascular system. You can get sometime the right infraclavicular pulsation, which is also at the area of right sternoclavicular joint. So a pulsation at the right infraclavicular area may suggest that this is in most of the time we have a left aortic arch. However, in patients with a right aortic arch, which you see in few congenital conditions like a tetralogy of Fallot, you may be able to see the prominent right infraclavicular or right sternoclavicular joint pulsation in cases of right side aortic arch. Also in patients with TOF who have underwent a BT shunt. BT shunt is usually autopulmonary shunt, which is a palliative shunt done in this condition. You may be able to find the right sternoclavicular pulsations. And also in cases of aortic aneurysm, like the ascending arch aneurysm, you may be able to see the right infraclavicular pulsation. So these are the conditions where you get the right sternoclavicular or infraclavicular conditions. Then we have right supraclavicular pulsation, which is usually seen in cases with chronic severe aortic regurgitation, where you get the dancing carotids, and also you can get the right supraclavicular pulsations in usually in cases of aortic regurgitation. The suprasternal pulsations are very important because they suggest increased flow across the arch. So any condition which causes an increased flow across the arch, let it be aortic regurgitation in a patient with hypertension, in patient with patent ductus arteriosus, or apart from this conditions like the autopulmonary window and all, and where hyperdynamic conditions like anemia, thyrotoxicosis and on, you can get supraesternal pulsation. So supraesternal pulsation suggests that there is increased flow across the arch. So you should always look for the supraesternal pulsations. The left supraclavicular or infraclavicular pulsations are usually seen in patients with PDA. We know that the PDA murmur is best heard after the left first intercostal space in the left infraclavicular area, and this is the area where you should look for the supra and infraclavicular pulsations. Now, next important are the right and left second intercostal space pulsation. First, coming to the right second intercostal space pulsation, as I already discussed, we see it usually in patients with ascending aortic aneurysms, and that is the most important condition where we get the right ascending intercostal space pulsation. Also, apart from this, we should also know that the ascending aortic aneurysm can be diagnosed clinically. We know that the right intercostal space or right parasternal pulsations are where the ascending aorta is usually located. Apart from this, the arch aneurysms are usually diagnosed by the Oliver sign, as you would have been already knowing. However, there is no, apart from clinical condition, where it is possible to diagnose the descending aortic or descending thoracic aortic aneurysm. So these are the various causes of the right second intercostal space pulsation. The left second intercostal space pulsation most commonly are found in patients with a dilated pulmonary artery. So the patients who have PAH, you will get the left second intercostal space pulsations. Also, you have to see for other finding of PAH like the palpable P2 in the left second intercostal space, and on percussion you will get a dull note on the left second intercostal space. These are the findings which tells that the pulmonary artery is dilated. However, apart from the pulmonary artery hypertension, in patients with normal pulmonary artery pressure also, you may be able to get a left second intercostal space pulsation, especially in patients with atrial septal defect, where because of the increased flow through the pulmonary artery, you get a pulsation in the left second intercostal space, and still the P2 may be palpable without evidence of pulmonary artery hypertension. There is one more congenital heart disease where you can find the left second intercostal space pulsation where there is no pulmonary artery hypertension, and it is the and aorta, which is the L pose aorta. It is known as the LTGA, or the congenitally corrected transposition of great arteries, where you can feel the aorta in the left second intercostal space, and that is why the left second intercostal space pulsations are there. And also you may be able to palpate the aorta in such cases. Now, apart from this, you can also see the epigastric pulsation. When you are able to see the epigastric pulsation, most of the time it suggests that there is an underlying right ventricular hypertrophy, which you are able to see as the epigastric pulsation. Parasternal pulsations are again important. We can see in various causes of pulmonary artery, dilated pulmonary artery, or in patients with atrial septal defects, where we can get a parasternal pulsation. So these are the various pulsations which you should see, and you can derive sometime come at some conclusion based on this pulsation. Now, always you should see in all the cases of cardiac examination whether there is a previous any scars or not. Most of the time in a valvular heart disease or not, like a patient have undergone any but open or closed mitral valvotomy. In those cases, you may be able to see a left-sided scars in the chest. However, the left-sided scars also suggest that the patient would have undergone a coarctation repair, or sometime it is no a modified Blalock tossing shunt, which is done as a palliative surgery. It is autopulmonary shunt done in patients with a tetralogy of Fallot and like conditions. PDA in children, if it's a PDA is ligated, apart the surgical intervention for PDA is done via the left scar. Minimal invasive CABG, apart from the central scar, it can also be done via the left thoracotomy scars, and also the closed mitral valvotomy, which can be done via the left side of the chest. The right-sided scars usually are seen in patients who have undergone mitral valve repair or replacement, patients who have undergone tricuspid valve repair and replacement, in a patient who have undergone ASD surgical closure, and in the patient who have undergone BT shunt. So Blalock toxic shunt, which was in the past done, uh, is always done on the opposite side of the arch. So normally in a patient with left arch, it is always done through the right side, and that is why it is currently not done. Most of the cases which are done now are modified BT shunts. We know the central scars are seen usually in patients with bypass surgery who have undergone, and the central shunts, autopulmonary shunt like the Potts and Watterson shunts and the Melbourne shunts. So these are the various scars you should always see. Apart from the CABG scars, you should also see the scars from where the veins are taken, like in the leg, saphenous vein grafts are taken on the both the legs, or the radial artery on the left, usually taken from the left radial artery. So those scars can be seen showing the underlying CABG. Now, coming to the palpation of the cardiovascular, you should always, the most important thing lies about the apex beat, and that is what our main topic of discussion is today, to palpate the apex beat, to palpate the parasternal hue, to palpate the thrills, and you have to also palpate for the direction of flow in the vein and palpate for any tender points. Now, these are the various areas which I showed you. You should always look in inspection and palpation, suprasternal notch, sternal angle, right and left sternal angles. You should always try to palpate in the tricuspid area, where you can be able to feel for a RVS3, RVS4, mitral area, where you may be able to feel for the LVS3, LVS4, and other diastolic events like a pericardial knock or a tumor plop or a opening snap, which may be rarely palpable too. In the epigastric area, you should be able to palpate for a epigastric pulsations. On the left parasternal area, you should also be able to palpate the parasternal hue and see for the parasternal pulsations. In the pulmonary area, you should be able to feel for parasternal pulsations, and also the palpable P2 should be seen. In aortic area, most of the time we know that the aortic the aorta is not palpable. However, in cases of a bicuspid valve with a dilated aorta, we may be rarely be able to palpate the aorta also, and sometimes the ejection sounds in this area can be palpable. Apart from that, there are few other rare things like the pericardial rub, which should be palpated, and also the thrills. Thrill is the one thing which is very important. we'll go discuss little bit in detail. So these are the various palpatory things which we should see in all these areas. Now, the general rule of palpation says, I think if this will be reading from your MBBS days, these are the three areas: the fingertips, the base of the fingers, and the base of the hand. We know the base of the hand is best for the parasternal hue and parasternal lift. The difference which we will discuss in the further slides. The thrill is best palpated at the base of the fingers, where the thrill is, and it is like the purring of the skin of a cat. It is how it is felt as. And the localized pulsations like a S3, S4, or even S1, S2, or a pericardial rubs and all things, even a cardiac apex. First, it should be after localizing with the full the palm, you should be able to localize it with the tip of fingertips. So these are the general rule how a cardiac palpation has to be done. Now, coming to the apical impulse, in the exam, they have a tendency to ask, how do you define apical impulse? So it is the lowermost and the outermost point of maximum cardiac impulse. So a maximum cardiac impulse, also known as point of maximum intensity, PMI, is the lowermost and the outermost point of, is the apical impulse is the lowermost and outermost point of maximum cardiac impulse from the sternum. Now, there are some few general rules about the apical impulse, which we should all know, because unless we know the basic rule, we may not be able to know how this apical impulse varies in different conditions. So normally the apical impulse is formed by the interventricular part of the LV. So the interventricular septum is there, the LV part of the interventricular septum. The interventricular septum has the RV part and the LV part. So it is the LV part of the interventricular septum which forms the apex. A normal apex is located in the fifth intercostal space on the left side. It is within the mid-clavicular line, and it is located 10 centimeter from the mid-sternal line, and it should be 1 centimeter within the mid-clavicular line. So these are the general basics which all of you know. And the normal apex is usually LV type of apex. It is a LV type of apex, but it is not downward and outward. It is in the fifth, but it is a formed by LV. That is, it is a LV type of apex. We know a normal apex is a tapping apex, which usually touches your finger but does not lift it. However, the only difference from a tapping apex is that it is not associated with a loud S1, a normal apex. It does not occupy more than 2.5 square centimeter, and it should be limited to less than one intercostal space. Some people say it should be confined to less than 1.5 intercostal space, but one intercostal space is fair enough. But the area is only 2.5 centimeter square, and as confined to the duration, it should be less than one third of the systole. So it should never raise your finger more than one third of the systole, because we know anything which lifts one third to two third is known as a hyperdynamic, and anything which raises your finger more than two third is a heaving type of apex, which will come to the next slide. So this is a normal apex, how you have to define a normal apex. So under this points, a normal apex should be told. Now, this is, I told you first, apex should always be palpated in only two important. It should be in the lying down position, and it should be in the left lateral position. You should never try to palpate for a apex in the sitting position, and it may give a wrong impression of a cardiac apex. So try to first localize find the apex with the base of your palm, and after you find for the apex, you try to localize it with the one of the fingers. So this is how a cardiac apex is palpated. Now there are many conditions where you may not be able to feel for a apex, and the examiner may ask you why you did not get a apex. Many a time in the obese patient, or if the apex is behind the rib, you may not be able to palpate. In a thick chest wall individuals and patients with emphysema and all, because there is too much lung may cover the part of the heart, you may not be able to feel. In patients with significant pleural and pericardial effusion, you may not be able to feel the apex. Also, if the patient has dextrocardia and you are looking for the apex at a wrong place, then you may be able to miss the cardiac apex. So these are the conditions where you should be able to feel for the apex. Now, coming to the most important point, what is a LV apex and what is a RV apex? Now, this is the most important thing which you will get confused most of the times. However, the basic rule, I think you should always remember, a LV apex which is formed by use is usually a localized apex. Two important points. LV apex is a localized apex. Second, LV apex is always shifted down and out. We know a RV apex is usually diffuse. RV apex doesn't have a spatial character. However, a LV apex is always shifted down and out. So if you are finding a apex in the fifth intercostal space in a normal size individual, it can never be a, it can still be LV apex, but it should be ideally a LV apex should be down and out. But a LV is usually a localized. So in cases with aortic stenosis or in cases with hypertrophic cardiomyopathy, where you find the apex in the same position, you should never tell it is what type of apex. However, if you are finding a apex which is shifted down and out, like in the sixth intercostal space and in the outside the mid clavicular line, it is a LV type of apex. However, RV apex is a diffuse apex. You may not be able to feel its heaving property or a hyperdynamic property. However, it will be diffuse. So RV apex is always diffuse, whereas the LV apex is localized. Now, next important thing which they will ask you is retraction. We know when RV dilates in patients with example pulmonary artery hypertension, atrial septal defect, the RV dilates and RV occupies the portion of the LV. In that case, what you will get is, because the RV is occupying the portion of the LV, you may be able to see the lateral retractions. So there will be lateral retraction because the RV is occupying the position of the LV. The RV, you will see the retractions which are lateral to the apex as compared to the LV. Whenever the LV dilates, we know that there is a counterclockwise movement. The LV is usually, it moves posteriorly, and you will be able to see the retraction which are medial. So you'll be able to see the retractions which are medial to the apex. So medial retraction is consistent with LV, and our lateral retractions are consistent with RV. Now, third important point which differentiates the LV and the RV is continuous with the parasternal heave. Now, suppose you have a case where you get a parasternal heave, like a parasternal heave type 1, type 2, type 3. You see whether the parasternal heave and RV apex are continuous with each other. It means there should be no area of silence in between the apex and the heave. So if they are continuous with each other, it is a RV type of impulse. If the apex and the parasternal heave are not continuous with each other, it is a LV type of impulse. These three are the basic rule where how you have to differentiate the LV and the RV apex. Apart from this, there are soft findings, like if you are having a patient with pulmonary artery hypertension, then you are very sure that you are having a RV type of apex because of the pH. The RV hypertrophy dilates and it occupies the apex. So in those cases where you get the other findings of pH, you are very sure that you have a RV type of apex. Suppose you get a RV epigastric pulsations. So you know how do you palpate for epigastric pulsation with the tip of the finger, tip of the right thumb in the epigastric area. The tip should be pointed towards the left shoulder with the breath held in end inspiration. If you are able to feel for the pulsation at the tip of your finger, they are the RV pulsation. Means it is because of the right ventricular hypertrophy you are getting the pulsations. If you are feeling at the pulp of your finger, they are the aortic pulsation, which is because of a dilated descending thoracic aorta. However, if you are feeling the pulsation in the lateral border of the finger, then it is the lever pulsations in cases of tricuspid regurgitation or tricuspid stenosis or other PH with RV dysfunction, you are getting the pulsations. So this is how you have to differentiate between a LV and a RV apical impulse. Now, apart from this, there is also something known as a LV dysfunctional apex. A, this we can discuss usually after the we discuss a hyperdynamic and a heaving apex. Uh, yeah. So there are three different types of apex. One is the tapping apex, one is the hyperdynamic apex, and third is the heaving apex. A tapping apex, we know it doesn't raise your finger, so the duration is less than 1/3 of the systole. So it doesn't raise your finger. However, if it is associated only with a loud S1 or a palpable first heart sound, we know most of the time it's not the palpable first heart sound, it is only the tapping apex which we say is the palpable. So if it is associated with a loud first heart sound, and if it is palpable but it does not raise your finger, then it is called as a tapping apex. The most important thing is it should never be displaced. So in cases of mitral stenosis, if it is an isolated mitral stenosis, the apex should not be displaced either out or down. It should not be able to lift your finger, and then the and it should be associated with a loud S1. So this is called a typical tapping apex, which we see in a mitral stenosis. Apart from this, there are two different type of apex, which are the hyperdynamic and a heaving apex. We already know what are these apex. However, how do you differentiate based on various variables? So on the basis of time, we know that a heaving apex, the LV ejection time is increased because of the pressure hypertrophy, like cases of systemic hypertension, aortic stenosis, hypertrophic cardiomyopathy, and coarctation of aorta. These are the various conditions which increases the duration. Apart from that, even in patients with LV dysfunction, we get a heaving type of apex, which is not localized, but which is diffuse. So if it is increased in time, it is a heaving type of apex. Hyperdynamic apex is usually does not increase in time because the LV ejection time remains the same. As compared to the amplitude, a heaving has an increased amplitude, and both a hyperdynamic have a both of this lifts our finger. However, it only relates with the time of the cardiac cycle for which it is lifting your finger. So if lifts your finger more than two-thirds of the systole, then it is known as the heaving apex. And if it lifts your finger for less than one, actually to be more concise, you should see if it is less than one half or half or less than half of the systole, then it is a hyperdynamic. However, the definition say anything which is between one-third to two-third, it is a hyperdynamic apex. Now, location is a heaving apex usually occupies only one intercostal space, and mostly a heaving apex because of the aortic stenosis and hypertrophic cardiomyopathy or related with coarctation of aorta, it will always be in fifth intercostal space. However, a hyperdynamic apex occupies more than one intercostal, so it should be shifted down and it should be shifted out. And it is always seen in various regurgitant lesions like severe MR, severe AR, or other high volume states like the VSD or a PDA, or in cases of other high output states. So AR, MR, VSD, PDA, and other high output states are typical example of a hyperdynamic apex, whereas a hypertension, AS, coarctation, and hypertrophic cardiomyopathy are the typical examples of heaving apex. Now, coming back to the LV dysfunction apex. Now, suppose a patient has a orthopnea of PND, and you have to tell that it is that there is some LV dysfunction. You should look for a apex which is a heaving, but it should be diffuse. You should be able to feel the heave, but you should not be able to localize it to the one place. So, a diffuse and heaving apex is one of the typical examples of LV dysfunction. There is one more example where you get a diffuse and the heaving is the left ventricular aneurysm. In patients who have a history of myocardial infarction can in the future develop aneurysm of the LV, where they can have a diffuse and a heaving type of apex. Now, to analyze the apex beat, if it is a forceful, you should see whether it is forceful or not forceful. A non-forceful apex, you should always see whether there is a loud first heart sound or not. A S1 palpable is very rare event, though we know S1, S2, S3, S4 all can be palpable, but it is mostly the low pitch sounds like the S3 and S4 which are palpable, and S2, P2 can be palpable. A2 and S1 are rarely palpable events. So if S1 is palpable or a loud first heart sound is there, then you have a tapping apex. However, if the S1 is not palpable or the first heart sound is not loud, it is a normal apex. So a normal apex, we know if it is displaced, we should always think for other conditions like the anemia and other non-cardiac causes. And if it is a forceful, you should see if it is sustained or not. A forceful and sustained apex is known as a heaving apex, and typical examples are hypertension, AS, coarctation, and hypertrophic cardiomyopathy. And if it is not sustained, it is a typical volume overload like AR, MR, VSD, and PDA. So it should be down and out, and it is usually localized apex. Now, coming to the parasternal hue, which we know that it is a palpable thrust which lifts the palpating hand. So which we should always feel with the pulp of our hand, and it is seen in various conditions of a right ventricular hypertrophy. Basically, the RV can be diastolic overload or can be systemic overload. I will discuss the parasternal lift, which is not a parasternal hue. Parasternal lift is different, but parasternal hue usually suggests that it is a right ventricular hypertrophy by either a volume overload or by a pressure overload. So there are two methods. One is by the ulnar border of the hand, we can feel that, and one second is by uh, the pulp, as I already told, the distal part of this pulp of the hand hour, we can feel for the parasternal heave. So these are the two things. Now, how do you define? It is only in the Indian system that we define and grade a parasternal heave, because it was first told by the Ames. So it is known as the Ames grading of parasternal heave. So grade 1 is visible but not palpable. It is usually seen when you put a pencil at the left sternal border. It will be just moving. So that is a grade 1. However, grade 2 is it is visible and palpable, and it is usually obliterable. When you keep your ulnar border or the pulp of the hand, it is usually palpable and you will be able to obliterate by some force. If it is grade 3, it is palpable but not obliterable after full force of the hand. It is usually seen in patients with right ventricular hypertrophy. Now, as I already told you, there are pressure overload conditions like a patients with severe pH of various causes, and mainly in conditions of pulmonary stenosis, severe pulmonary stenosis. It is a pressure overload which causes. However, it can also be seen in a volume overload conditions like a left to right and in patients with ASD and VSD. Now, how do you differentiate is usually in patients with ASD, VSD, where there is volume overload, you will get only grade 1 to 2 parasternal hue. However, in cases of pulmonary stenosis, you get typical grade 3 and well sustained. It is a well sustained, it is a late peaking. However, in volume overload, it is a fast, it is a ill sustained parasternal impulse. So this is how we differentiate. Now, there is another thing known as a parasternal lift. Usually, people tend to confuse between a parasternal hue and a parasternal lift. The main difference is in patients with mitral regurgitation, because the LA is too much dilated and all the regurgitant blood from the LV is going to the LA tends to bounce because there's such a huge LA, and this is the huge and it is posterior, and because the LA is posterior, all the blood is coming to it. We get a lift of your hand. So the lift of the hand, it is the parasternal lift. Usually we see in patients with chronic severe MR and not in cases of acute MR, where it is a small LA and not a large LA. So this is known as a parasternal lift. Now, how do you differentiate a lift and a hue? There are three important difference. The first important difference is a hue is usually well sustained, whereas a lift is usually ill sustained. That is the most important difference. A lift is usually ill sustained. Second, a hue is localized to the left sternal border, whereas a lift is usually a diffuse thing. So a lift is a diffuse, whereas a hue is a well localized to the left sternal border. The third important thing is usually a hue is pan-systolic, whereas a hue is a late systolic. Usually you get a hue in a late systolic, whereas you get a lift a lift in a late systolic, because it's in the later part of the systole that the LA is filling, whereas a hue is usually a pan-systolic event. So these are the three important difference between a lift and a hue. Normally, we get it in a mitral regurgitation. It is also known as squid effect. It is known as a seesaw motion or a rocker bottom motion of the precordium. However, you can also get it in cases with a severe tricuspid regurgitation or functional tricuspid regurgitation, where the RA is very huge, and also in patients with aortic regurgitation, you get a lift of the precordium. So these are three are the conditions where you can get a LA lift. Now, apart from this, coming to the other palpatory findings, we can even palpate the heart sounds. Now, as I already told, there are low frequency sounds like the S3 and S4, which can be palpated at the left parasternal area. Now, when you are able to palpate for a RVS3, it always suggests that it coincides with the RV dysfunction or a RV failure. Means the patient has a severe tricuspid regurgitation, atrial septal defect. Now, when you get a RVS3, you will invariably get in JVP a prominent Y descent. So a prominent Y descent in JVP correlates with a RVS3. Now, this usually suggests RV failure. However, RVS4 is usually seen in patients with severe pressure hypertrophy of the RV, like in patients with pulmonary stenosis or conditions where RV compliance is decreased, like in patients with pulmonary hypertension. So these are the conditions where you get a RVS4. So RVS3 is very common event. RVS4 we usually do not find, but you should always look that in patients with a pulmonary stenosis and severe PAH without RV failure. So a patient, how do you diagnose right ventricular hypertrophy? Is left parasternal pulsations, heaving parasternal heave, and left parasternal lift. So this is how you should be an epigastric pulsation. So this is how you diagnose a RVH. Now coming to the pulsations in the left second intercostal space, as I have told you, but just revise that it always suggests a dilated pulmonary artery, and pulmonary artery pulsations can be in systole. However, a palpable P2, which is also known as a diastolic shock, in patients with severe pulmonary arteries hypertension, we get a palpable P2, and that is known as a diastolic shock. However, if it is a systolic, it is known as a PA pulsation, and usually we get in patients with a pulmonary artery hypertension. However, in absence of pulmonary artery pulse, hypertension, if we are getting, we should always suspect atrial septal defect, because there is too much blood flow into the pulmonary artery, because of which P2 is palpable and the second intercostal space pulsations will be there. One more differential, as I already told you, is CCTGA, LTGA, where because there is a L post aorta, you get a pulsations in the left second intercostal space with a palpable A2. Even in case patients with aortic aneurysm, we can get a left second intercostal space pulsation, and rarely in patients with the LA enlargement, we get a left second intercostal space pulsations. Now, coming to the LVS3 and S4, that is one important thing, as I already told you. We should always know that these are the low pitch sounds. Both S3, LVS3 and S4 are low frequency or low pitch sound are better appreciated putting a light pressure by the finger. And as you increase the pressure, they will get dampened. We know that the breath should be held in end expiration or in the expiration to feel for this. So S3 and S4 are usually palpable best when the fingers are kept very light, and as soon as you try to make it firm, the S3 and S4 will disappear. Now many a time the examiner will ask you which of this sound is better palpable and which is better auscultable. It is always that S4 is better palpable than auscultatory, whereas the S3 is better auscultated than felt. However, anything can happen. However, it is not a generalized rule, but reverse can also happen. Now, whenever you are able to feel for a S3, you should be able to feel with the light hand, and as you increase the pressure, your S3 will disappear. Same happens with the S4. Now, we know that the S4 correlates with the increased LV compliance, and the S3 suggests that there is a failing of the left ventricle. So that is one very important message. We get a palpable S4 in conditions like a hypertension, HCM, and in aortic stenosis. Important thing is in patients with aortic stenosis, if you get a palpable S4, it means it's a severe aortic stenosis, and the gradient between the LV and the aorta will be more than 75 mm of Hg. However, in case of hypertrophic cardiomyopathy, if you get a S4, it means that there is a strong atrial contraction and you get a triple apical impulse. Normally, we get a double apical impulse. The first apical impulse is formed by the LV ejection, then there is a SAM, then there is a second LV ejection followed by atrial contraction, which contributes to S4. So that is a triple apical impulse in patients with hypertrophic cardiomyopathy. In patients with hypertension, we should always be able to try to auscultate S4 if not palpate. So these are the condition where you get a palpatory S3 and S4. The one important differential diastolic event is a pericardial knock, which is usually a palpatory as compared to the tumor plop, opening snap, which are though diastolic sound and can rarely be palpated. The pericardial knock is the best palpatory event in a diastole, and it is usually palpated at the 10th and 11th intercostal space on the posterior axillary line or the scapular line. Because what happened in case of constrictive pericarditis, there is a systolic retraction of the whole of the pericardium. We know because there is a constriction, there is a systolic retraction, and during a diastole time, only for some time the pericardium movements come out. So it is the systolic retraction of the whole of the pericardium which is can be felt by our hand, and it is known as a broadband sign. So pericardial knock can be palpated in a patient with constrictive pericarditis. So as I already told you, a palpable S3 most commonly suggests that it is a failing LV. Apart from that, we even in patients with uh, severe MR, we can get S3. However, in aortic regurgitation, if S3 is there, it means the LV dysfunction has set in. Again, a palpable S4 is seen in AS, hypertrophic cardiomyopathy. In acute MR and acute AR, you may get because the LV compliance is not good. So these are the conditions of a palpable S4. Now, I will discuss this slide, but you should always remember that these are very rare events which can be palpated. S1 is usually we cannot palpate. We can usually, if it is a loud S1, we know it is a tapping apex. So it is a tapping apex which we are able to palpate and not a S1. And then opening snap, though it is written, it is very rare, difficult to palpate opening snap. A tumor plop, which we see in patients with LA myxoma, it is difficult to palpate, and a systolic ejection sound. We know that as ejection clicks are there, but ejection clicks are rarely palpable when there is a congenital bicuspid aortic stenosis. So these are the other sounds which can be palpated. Now, again coming to the palpation of the lower left sternal area. Yeah. So next important thing are the thrills which we have to always look for. So thrills are palpable vibrations of murmurs which accompany any organic murmur. A thrill we know has three important things. A thrill tells that the murmur is organic. That is first thing. The exception to this rule is many a time there are many functional events like in cases of severe anemia, thyrotoxicosis, and many other places where we rarely get a thrill. Means it is a function. So though the rule is thrill is usually says that the murmur is organic, it localizes the murmur and it tells that that the disease is severe. So it localizes the murmur. It tells that it is organic, and it tells about the severity. So this thing, three things are true about any thrills. Now, thrill, as I already told you, it is best heard with the base of the finger, and even some people try to feel it with the fingertips. A thrill. Now, there are various locations based on which you can diagnose what type of thrill it is. Coming to a diastolic thrill. A diastolic thrill at the apex is usually consistent with a mitral stenosis, and it is usually localized to the apex. It indicates that the valve is mobile and it is a non-calcified valve. So unless a valve is mobile and non-calcified, you may not be able to feel for a diastolic thrill. And if the thrill is equivocal, even in left lateral position, you can try to do something which can increase the LA pressure, like exercising, asking the patient to cough, where the heart rate and LA pressure increases, and you may be able to feel for a thrill. Next are systolic thrills at the apex. Now, one important thing is many people think that MR is something where the thrill is very common systolic. However, this is not true because in mitral regurgitation, all the regurgitant blood from LV goes to the LA. And as the blood goes to the LA, it is going away from your finger. And because it is going away from your finger, it is not very common to get a thrill in mitral regurgitation. So a thrill in mitral stenosis is more common than a thrill in mitral regurgitation. However, this is not true. In patients with caudal acute MR, like a caudal rupture and all, it is very common to get a thrill in MR, and this thrill can even radiate to the base of the heart, and even the murmur can be go to the base of the heart. So that is one condition where a systolic thrill of MR is common. However, if you are getting a systolic thrill or of the apex, always look for the second differential diagnosis like AS, which will have a thrill at the second intercostal, but rarely the thrill may be traced up to the apex. That is the galavadin, but the thrill can sometimes radiate up to the apex in cases of aortic stenosis. Also, you should look for the thrill. If you are seeing at the apex, you should always see that whether it is a thrill of ventricular septal defect. So a ventricular moderate size or a significant VSD is associated with the thrill in the left lower sternal border. That is the left intercostal space, and it should be associated with a pansystolic murmur. And if the shunt is more, you should be able to get a LVS3 and mid diastolic murmur across the mitral valve. So these are the few things where you should be able to get a systolic thrill. However, in a patient with VSD, if the thrill is more up, like third and fourth intercostal space, you should think of some different type of VSD, like a subarterial VSD or a double chambered right ventricle, those type of VSD. Also, systolic thrill at the second left intercostal space is very common in patients with pulmonary stenosis. So all the pulmonary stenosis, let it be mild, moderate, severe, means more than mild, are invariably associated with a systolic thrill at the left second intercostal space. However, in a patient with ASD, if you are finding a thrill in the left second intercostal space, you should always suspect that the patient may have an underlying pulmonary stenosis, or the patient may have a very large ASD, or it is associated with a Lutembacher, like a mitral stenosis with ASD. So those are the cases where you get a thrill in patients with aortic stenosis in the left second intercostal space. Now, coming to again the thrill, if you get a thrill at the apex, it can be diastolic and systolic. You should always time it with the cardiac cycle. And the diastolic thrill of mitral stenosis is much more commoner than a systolic thrill of mitral regurgitation. However, in acute severe MR, due to caudal rupture, you may still get a thrill at the apex uh, and at the base of the heart, but you should always suspect that the patient may have a AS, and always look for other findings of the aortic stenosis. In tricuspid area, the most common thrill to get is a diastolic thrill of a tricuspid stenosis. And a diastolic thrill of tricuspid stenosis, it correlates in JVP with a prominent A wave. So a prominent A wave correlates with the diastolic thrill, and you should get absent Y descent in all such cases. So a prominent A wave, absent Y descent, a diastolic thrill, and a flow murmur across the tricuspid area are important findings of a tricuspid stenosis. Systolic area of tricuspid regurgitation is very rare, though. The pulmonary area, as I already told you, the first thing to think for systolic thrill is pulmonary stenosis. Then the other conditions like ASD with PS, ASD with Gutenberger, and a large ASD you should think of. Getting the lower down in the third and fourth intercostal space, you should think that the patient has subarterial VSD or a double chambered right ventricle. If you get a continuous thrill all over the precordium, you should always suspect for conditions like a patent ductus arteriosus and a ruptured sinus of Valsalva. If the thrill is again localized to the aortic area, you should always suspect it is a aortic significant valvular aortic stenosis. Now, apart from this, if you get a thrill at the carotid and the carotid suddar, you should always suspect that the aortic stenosis is there. A systolic thrill, aortic thrill suggests that the AS, whereas a diastolic thrill, it suggests the AR. We should always remember that in AR, the diastolic thrill is very uncommon, like a systolic thrill of MR, though it is more uncommoner than the systolic thrill of the MR, a diastolic thrill in AR. The pulmonary thrill, if it is systolic, it is usually PS, ASD, again, Lutembacher or a large ASD. And if it is a continuous, you should always suspect PDA and rupture sinus of Valsalva. Lower sternal border, if you are getting a thrill, it is always suspect a VSD. And in the apex, if it is a systolic thrill, it's a MR, whereas it diastolic thrill, it's a MS. So this is basic about the thrill you should always know. Now there is one more sound which I have already told you is about a pericardial rub. It is a very rare to get a palpable pericardial rub, though we should always remember that a opening snap, a pericardial rub, a tumor plop, and a S1, though they are very rare to get palpated, they can still be palpable. And it is best felt at the lower sternal border with the patient in sitting and leaning forward, where the pericardium comes in contact. So it will be best heard in the patient in sitting and the leaning forward. So this is one thing about the pericardial rub. I have not put a slide on the percussion, but I want to tell about the few points of cardiac percussion which you should always know. We think that the percussion has always become a old finding and we should not do percussion. There are 3 to 4 conditions where we should always do a cardiac percussion. The first important thing is a patient with congenital heart disease. In patients with congenital heart disease, because you should always know the situs of the patient, whether it is a situs solitus or a situs inversus, so that you will know by percussing the right side and the left side. So if you are getting a liver dullness on the right side and a tympanic note on the left side, it means that the liver is on the right side and the gastric tympani on the left side. However, if there is a vice versa, then we can always suspect situs inversus, because we know that situs inversus is usually have a large tendency to be associated with complex congenital heart diseases. Second important thing about cardiac percussion is we should always percuss the left second intercostal space, because if the left intercostal space, which is normally resonant, if it becomes dull, we should always suspect that there is underlying pulmonary artery hypertension and a dilated pulmonary artery. However, there are other conditions which can cause the dilated pulmonary artery, like the idiopathic dilatation of the pulmonary artery. That is one condition. Also, in cases with massive pericardial effusion and a mediastinal tumor like thymomas, we can get the left second intercostal space as dull. Similarly, if you get the right second intercostal space dull, you should always suspect the ascending aortic aneurysms. Apart from that, even pericardial effusion and mediastinal tumors can cause a dull note in the left second intercostal space. The third important finding which you should do in a percussion is always percuss the right heart border. The left heart border percussion doesn't have much importance in the current in the cardiology. However, the right heart border percussion is very important because many a times we may be able to feel for a finding of a dilated RA, which otherwise is very difficult to diagnose clinically, a dilated RA. So how do we do a cardiac percussion is we always should start from the mid clavicular line in the second intercostal space, keep on going down till you get a, keep on percussing in each intercostal space till you reach the liver dullness. And once you reach the liver dullness, you come one space up and turn your fingers perpendicular. Now you should start percussing towards the sternum. Now when you percuss towards the sternum, you should get the dullness in the substernal area. However, if your dullness stops outside the lateral sternal border, it means that the RA is dilated, because normally the RA is substernal. Now, if your dullness stops outside the lateral sternal border, it means that the RA is dilated. So these are the few things where you uh, should be able to do in the percussion of the cardiovascular system. So these are the various things about the cardiovascular inspection, palpation, and percussion. And now coming to the epigastric pulsation. Now, as I already told you, epigastric pulsation, you should always palpate with the tip of the finger in the subxiphoid area. The finger should be pointed towards the left shoulder, and you should always do it in the patient breath held in and inspiration. You should be able to diagnose one of this if there is any issue like a RV or a aorta or a hepatic. If the pulsations are best felt at the tip of the finger, it means the right ventricular hypertrophy is there and it is RV pulsations. If you are able to feel the pulsation at the pulp of your finger, it means there are aortic pulsation because of a descending aortic dilatation or aneurysm. And if it is you are able to feel for the pulsation with the lateral border, it's there because of a hepatic pulsations because of a tricuspid regurgitation or a tricuspid stenosis. So these are the things which you should know. Because I discussed PS and TR, one important thing is you should always do per abdomen examination in on all cardiovascular cases, because if you have a hepatomegaly and if your liver span is increased, you should always see whether there is systolic pulsations of the liver or diastolic pulsations. That is the pre-systolic pulsation. Because if you get a systolic pulsations of the liver, it means you're dealing with the case of tricuspid regurgitation. However, if you are getting a diastolic pulsations of the liver, you or a pre-systolic pulsation, it means that you're dealing with a case of tricuspid stenosis. As I already told you, in tricuspid stenosis, you get a MDM at the lower left sternal border, a prominent A wave, a absent Y descent, a diastolic thrill will be there, and pre-systolic pulsations of the liver are there. Though the important thing is the organic tricuspid stenosis is a very rare part of congenital rheumatic heart disease. Also, sometimes the aortic regurgitation can also cause a diastolic pulsations of the liver. So these are the various things which you should know, because it is important in except for all exam purposes. So this is what I just summarized for you, and I would like to conclude here. Thank you.